Fantastic. So first of all, thank you everyone for joining us today. I hope that this session is both interactive and informative. If anyone has any questions throughout the lecture, feel free to pop them in the question and answer box, and we can try and get through them all at the end. So diving straight into our first question. A 20-year-old boy with a past medical history of Crohn's disease undergoes an abdominal ultrasound for recurrent bouts of abdominal pain. This shows a thickened gallbladder wall with gallstones inside. He is diagnosed with chronic cholecystitis. Which of the following are risk factors for gallstone disease? And we'll give you about a minute to answer this, and then we'll discuss it. Okay, and we'll go through the answers. So the correct answer, which most people got, was E, ileoresection. So bile salts are reabsorbed in the terminal ileum. So an ileoresection increases the risk of stone formation. The terminal ileum is most commonly affected in Crohn's disease, and so this patient may have had an ileoresection at some point in time. Estrogen-containing oral contraceptives are associated with a slightly increased risk of gallstone formation. However, there's no increased risk with oral contraceptives that contain progesterone. Female gender is a risk for gallstone disease in all age groups, not male gender. Enteral feeding isn't a big risk factor for gallstone formation. However, long-term TPN use is. This is thought to be due to the biliary stasis caused by a lack of gastrointestinal stimulation, and it may also be associated with liver dysfunction or fatty liver. And hyper, not hypobilirubinemia, is a risk factor for pigment stones. So, for example, disorders causing hemolytic anemia may also be associated with gallstones. So there are three types of gallbladder stone. Cholesterol stones are formed when the bile is supersaturated with cholesterol. So this can happen because of decreased bile acid production or increased cholesterol output in bile, or both. Cholesterol stones are associated with conditions that increase the excretion of cholesterol by the liver, such as oral contraceptives, pregnancy, cholesterol-lowering drugs, rapid weight loss, obesity, and TPN. Pigment gallstones typically form in conditions of stasis, so for example, parenteral nutrition, or conditions associated with excess unconjugated bilirubin, for example, hemolysis or cirrhosis. Mixed gallstones are the most common type of gallstones and are a mix of cholesterol, bile pigments, and calcium salts. So I thought we'd touch on risk factor for gallstones. For patients with cholesterol stones, it's important to remember the 4 Fs. So fat, female, 40s to 50s, and fertile. Obesity is thought to increase the risk of gallstone formation by increasing fasting and residual gallbladder volumes with residual bile stasis. Other risk factors include estrogen, so things like HRT or the oral contraceptive pill, pregnancy, rapid weight loss, a family history, TPN, or diabetes. Pigment stones may be associated in patients with cirrhosis or hemolytic anemias, so basically any condition that causes increased bilirubin in the bloodstream. In children with no significant risk factors for gallstones, pigment stones are the commonest type of gallstones within this age group. Risk factors for mixed stones are essentially the same as those for cholesterol stones, as cholesterol is the predominant constituent of mixed stones. Mixed stones are the most common type of gallstones you'll find. So our next question. A 32-year-old lady presents with a 10-month history of right upper quadrant pain that radiates around to her back. It usually comes on after eating and is exacerbated by fatty foods. On examination, her vital observations are stable, she is afebrile, and her abdomen is soft and non-tender. Blood results, including a full blood count, liver function tests, and amylase, are unremarkable. What is the most likely diagnosis? And we'll give you about a minute again. Okay, and go for the answers. Excellent. So the majority of people got this question correct. The answer was indeed biliary colic. So this is actually a really typical presentation of a patient with gallstones. The pain usually radiates from the right upper quadrant to the back, and bloods and observations are normal. After eating, the duodenum releases cholecystokinin, causing the gallbladder to contract, and the pain is caused by the gallbladder contracting against the stones within it. Patients with acute cholecystitis also present with right upper quadrant pain. However, they'd be systemically unwell, so they might be tachycardic or hypotensive, and their bloods would show raised inflammatory markers. Ascending cholangitis is an infection of the common bile duct, most commonly caused from stones that have passed into the duct and caused an obstruction. Again, the patient would be systemically unwell. Charcot's triad is observed in approximately a third of these patients and is a combination of fever, jaundice, and right upper quadrant pain. Here, the patient, however, has normal observations and normal blood results, so this is not the correct diagnosis. Acute pancreatitis typically presents with epigastric pain that radiates through to the back. The patient is likely to be systemically unwell and would have a raised amylase. Cholangiocarcinoma is usually found in patients who present with painless jaundice and a palpable gallbladder, and is likely to be accompanied by systemic features of weight loss and lethargy. They're usually a little bit older. So biliary anatomy is commonly quizzed in medical school exams, and a basic understanding will also help you in your foundation training. So gallstones are most commonly found in the gallbladder, and blood results are normal in patients with uncomplicated gallstones. Occasionally, gallstones can pass into the common bile duct, and if this were to occur, you'd expect the LFTs to be deranged. Moritzi syndrome occurs when the common hepatic duct becomes obstructed by extrinsic compression from an impacted stone in the cystic duct or Hartmann's pouch. This is rare but would be associated with a raised bilirubin and a raised ALP. And if your gallstone makes it all the way into the pancreatic duct, then this can cause gallstone pancreatitis. So the next question, a 58-year-old obese woman presents with acute onset abdominal pain. She is febrile and tachycardic. On examination, she's clinically jaundiced and tender in the right upper quadrant with a positive Murphy sign. What is the most likely diagnosis? I'll give you about a minute. Okay, so most people guessed B, which is acute cholecystitis. And that is the correct answer. Oh, sorry. the, the correct answer is actually ascending cholangitis. So the combination of fever, jaundice, and abdominal pain points towards a diagnosis of ascending cholangitis. Cholangitis is an infection of the common bile duct and or hepatic ducts, most commonly caused by stones that have passed into the duct and cause an obstruction to its outflow. The stagnant bile progresses to bacterial infection. Here, the patient is female, over 40, and obese, all of which are risk factors for gallstones. E. coli is typically the bacteria associated with these infections, and the patient may become septic. So, like we discussed earlier, a patient with biliary colic is likely to be systemically well. They usually have a long-standing history of pain after eating, which is caused by the gallbladder contracting against gallstones. Acute cholecystitis presents with the same pain as a patient with biliary colic, but you'd expect them to have raised inflammatory markers and be systemically unwell. Patients with acute cholecystitis would not be jaundiced. Carcinoma of the head of the pancreas can obstruct the common bile duct and cause jaundice. However, these patients typically present with progressive onset painless jaundice and would not be spiking temperatures. Renal colic should be remembered as a differential of right upper quadrant pain. However, the patient would display urinary symptoms and signs like urge, frequency, hematuria, and a patient with renal colic would not be jaundiced. So the next question, a 45-year-old female presents with fever and abdominal pain. On examination, she is sweaty but not jaundiced. She is tender in the right hypochondrium and epigastric regions and is Murphy's positive. She is pyrexyl, but her observations are otherwise stable. Liver function tests and lipase are normal. What is the best investigation to confirm the diagnosis? Okay, and we'll go for the answers. Excellent. So the correct answer was an abdominal ultrasound. So this is a fairly typical presentation of a patient with acute cholecystitis, and abdominal ultrasound is the first-line imaging technique for suspected gallstones and would also confirm a diagnosis of acute cholecystitis. You should always consider MI as one of your differentials in a patient presenting with epigastric pain, and an ECG and troponin can be used to investigate an MI. This patient, however, is displaying Murphy's sign, which makes the diagnosis of acute cholecystitis much more likely. An abdominal ultrasound is preferred over CT abdomen as it's more specific. It can also be quite hard to visualize the gallstones on a CT abdomen. So a negative CT doesn't rule out the presence of gallstones. If a perforation were suspected, then a CT with contrast would be required. So a CT pancreatic series is useful if pancreatitis was suspected. Whilst the patient has epigastric pain, the lipase in this case is normal. Lipase is more sensitive and specific than amylase as a diagnostic test, so pancreatitis is very unlikely here. And again, acute cholecystitis is not an indication for an abdominal X-ray. Abdominal X-ray is more useful for investigated suspected bowel obstruction or bowel perforation when used in combination with a chest X-ray. So when you're clerking in a patient, in general surgery, but also generally, you want to cover the history of the patient's symptoms. So is this a new problem? Is it a long-standing problem? You want to talk a little bit about their previous medical history and also their family history. You should always assess patients in an A to E manner, and there are some really simple bedside tests you can obtain on the ward. So like we discussed earlier, any patient with epigastric pain should have an ECG, and an erect chest X-ray. So the ECG is really important to exclude an MI, and your erect chest X-ray is really useful to exclude a perforation. An ABG and VBG are particularly useful. So if your patient's unwell, you'd normally perform an ABG over a VBG, but essentially both will give you a lactate. Your basic set of blood tests for almost all general surgical patients are going to include a full blood count, LFTs, UKMLA amylase, a coagulation screen, and a group and save if you think they're at risk of going to theatre. Other useful blood tests include a calcium, magnesium, and phosphate. Most patients will probably undergo some form of imaging if they present with abdominal pain. An abdominal ultrasound is a very common first-line imaging tool. Patients aren't exposed to radiation, and it can be quite useful, especially in Gallstone disease. Other imaging tools to consider are CT or MRCP if there is biliary tract pathology. So for anyone studying for exams, this is quite a useful summary cheat sheet, which you may want to screenshot. So I'll only touch on this briefly, and I hope that I might also be able to answer some of your questions with this. So one of the key ways to differentiate between biliary colic and acute cholecystitis is that a patient with acute cholecystitis will have raised inflammatory markers, and they'll be systemically unwell. So they might be tachycardic or they might be hypertensive. In the majority of these cases, the LFTs should be normal. So you won't ever see jaundice in these patients unless they've got an obstruction, and that automatically means it's not going to be a simple acute cholecystitis. So in patients with choledocholithiasis, which means gallstones in the CBD, this is when you'd expect your LFTs to be deranged and your patient to be jaundiced, and that is because you have a gallstone stuck in the common bile duct. Patients with CBD stones are usually investigated first with an abdominal ultrasound because this is a quick and readily available test. And patients then may proceed to an MRCP, but definitive management of patients with CBD stones is going to be ERCP. So in patients with ascending cholangitis, you may see Charcot's triad. So that's abdominal pain, fever, and jaundice. Raynaud's pentad is simply Charcot's triad, but with the signs of shock. So they might, so low blood pressure and confusion. Patients with ascending cholangitis need to go for an emergency ERCP because they can become very sick very quickly, and they need those stones removed. So moving on to our next question. A 63-year-old man is admitted with severe generalized abdominal pain. He has vomited 5 times and has not opened his bowels or past flatus for 2 days. He is on the waiting list for an elective cholecystectomy, but is otherwise usually well. He is tachycardic and febrile, and his abdomen appears distended. What is the most likely complication of his gallstone disease? Okay, and we'll go for answers. So the majority of people got this question correct. The answer is gallstone ileus. And this is because this patient has features of a small bowel obstruction. This is a rare but severe complication of chronic gallstone disease. So it typically occurs in older patients when a gallstone passes through a fistula between the gallbladder and small bowel before becoming impacted at the ileocecal valve. The fistula is able to form because there's been lots of chronic inflammation. It's not a paralytic ileus, rather a mechanical obstruction. If CT were performed, it may show air in the biliary tree, and treatment involves milking the stone proximal to the obstruction site and removing it via an enterotomy. Mertzi syndrome we touched on briefly earlier, but this is when the common hepatic duct becomes obstructed by extrinsic compression from an impacted stone in the cystic duct or the Hartmann's pouch. This is rare, but would be associated with a raised bilirubin and a raised ALP, and the patient would be jaundiced. Gallstone pancreatitis occurs when a gallstone becomes stuck in the pancreatic duct, and the patient would present with epigastric pain and a raised amylase. They would not present with features of bowel obstruction. And choledochlythiasis is simply gallstones in the common bile duct. Patients present with biliary colic and raised liver enzymes. Acute cholecystitis is the most common complication of gallstone disease, and although this patient is febrile, the abdominal distension and history of absolute constipation make bowel obstruction a much more likely diagnosis. So we've touched briefly on most of these, but common complications and less common complications of gallstones include acute cholecystitis, CBD stones, ascending cholangitis, gallstone pancreatitis, gallstone ileus, and gallstone adenocarcinoma. So a 35-year-old female presents with a right upper quadrant pain. She's febrile, but her other vital observations are normal. Blood show leukocytosis, but liver function tests, including bilirubin, are normal. An abdominal ultrasound reveals multiple gallstones in a thick-walled gallbladder. The bile duct, however, is non-dilated. IV antibiotics are commenced. What is the best course of action? Okay, and we'll go for answers. Good. Again, most people got this answer correct. So the patient with gallstone disease has been complicated by acute cholecystitis, and definitive surgical management is required on this admission. A lap chole should ideally be performed within 72 hours of presentation, and a laparoscopic approach is preferred over an open approach because it's associated with lower morbidity and mortality. In real life, you may find that some surgeons opt to perform a lap chole at a later point of time to allow the inflammation to settle, but your textbook answer and the recommended treatment is indeed a laparoscopic cholecystectomy within 72 hours. If surgery is considered too high risk, then a percutaneous cholecystostomy could be considered, but it's not the first line because a cholecystectomy has better outcomes. Just a couple of other things that will help you in your day-to-day life. So one of the key findings in this question is that the patient has a thick-walled gallbladder. So a thick-walled gallbladder means there's lots of inflammation, so it's kind of indicative of acute cholecystitis. In a patient with a normal gallbladder, it'll be described as a thin-walled gallbladder. It's also important to note here that the bile duct is not dilated, which means, or it suggests that no gallstones have passed into the bile duct. So biliary disease can be managed in a conservative approach with some patients. However, some patients require surgery or surgical management. So for example, simple biliary colic may be managed with analgesia, and the patient may be listed for an elective lap chole at a later point in time. Patients with acute cholecystitis should be offered a lap chole within 72 hours of presentation. Patients with CBD stones or ascending cholangitis should undergo an ERCP. You should always assess an unwell patient in an A to E manner, and for septic patients, you should aim to complete the septic 6 within the first hour. No matter what the underlying pathology, if you're ever concerned about one of your patients, it's really important to get senior input early. So a 46-year-old man underwent a laparoscopic cholecystectomy 2 days ago. The operation was technically difficult and a biliary drain was left in situ. Today, he has had increasing amounts of abdominal pain and has required regular opiate analgesia. He is febrile and tachycardic, and the drain appears to have bile in it. His blood show stable hemoglobin but deranged liver function tests. What is the most likely postoperative complication that has occurred? Okay, we'll go for some answers. So the correct answer was indeed bile leak. And before we explain the answer, it's really important to note here that this is an unwell patient. So he's febrile, he's tachycardic, and he's somebody you would want to be escalating to your seniors quite early on. So the presence of bile in the drain with abnormal LFTs make a bile leak the most likely diagnosis. And essentially a bile leak can occur if the clips in the cystic duct slip or if the common hepatic or bile duct have been injured intraoperatively. The other key thing to note in this question is that this was a difficult operation, and bile leaks are more common if it has been quite a challenging operation. ERCP can be used to identify the site of the leak and can also allow for temporary stenting, which in turn allows biliary drainage. It's important to remember that a bile leak is quite rare, so for an experienced surgeon, the incidence of a bile leak occurring is approximately 1 in 700 laparoscopic cholecystectomies. An abscess is a late complication of surgery and is unlikely to occur within 2 days. Abdominal bleeding would be associated with a reduced hemoglobin, and the patient may be hemodynamically unstable. Post-cholecystectomy syndrome is essentially recurring abdominal pain and reflux symptoms, which can present months or years after the initial surgery. And these symptoms aren't described here. Whilst opiate-containing painkillers are a risk factor for paralytic ileus, the patient would present with absolute constipation and or vomiting, which are not described here. Or Hartmann's. It's important to remember some of the postoperative complications that can occur with any type of biliary surgery. So those would include bleeding, infection, abscesses, DVTs, PEs, or various injuries to other bowel. In terms of biliary surgery specific complications, you may have some missed CBD stones. You can have a bile leak, so that's when like we discussed earlier, so the clip on the cystic duct becomes slipped, or for example, an iatrogenic injury or a stump leak. And you can have post-cholecystectomy syndrome. So an 82-year-old man presents with progressive painless jaundice, itching, and unintentional 3-stone weight loss. On examination, he is afebrile and clinically well. Examination reveals hepatomegaly, and cholangiocarcinoma is suspected. Which of the following is a risk factor for bile duct cancers? Okay, and the correct answer for this is inflammatory bowel disease, which again most people got. So inflammatory bowel disease is associated with an increased risk of cholangiocarcinoma, particularly if the patient also has primary sclerosing cholangitis. Von Hippel-Lindau gene is a gene implicated in clear cell renal carcinomas. And polycystic liver disease is a risk factor, but polycystic renal disease is not. Male gender is a risk factor for cholangiocarcinoma rather than female gender. And aromatic amines are an occupational risk factor for transitional cell carcinomas of the bladder. And again, this is quite a typical medical school exam question. So Cravosies' law states that a palpable gallbladder in a jaundiced patient is unlikely to be caused by a stone. So this is because the gallbladder in gallstone disease is likely to be thickened and fibrotic and therefore small and unlikely to be palpable. In malignancy, however, the gallbladder is thin-walled and has the capacity to dilate. There are some exceptions to this rule, however. So if a patient has a CBD stone, for example, the patient might have a normal gallbladder with the capacity to dilate. If a cancer of the bile ducts arises above the origin of the cystic duct, then the gallbladder is distal to the obstruction and will be collapsed and empty, so not palpable. Risk factors for biliary cancers include male gender, obesity, smoking, aged over 50 years, recurrent stones, and congenital abnormalities. And the majority of these cancers are adenocarcinomas. And finally, on to our last question. A 21-day-old baby presents with jaundice. He was full term, normal birth weight, and appeared well until recently. Blood results show a conjugated hyperbilirubinemia. What is the most likely diagnosis? Okay, and the correct answer is biliary atresia. So biliary atresia is essentially a blockage in the ducts that carry bile from the liver to the gallbladder. This neonated jaundice with a conjugated hyperbilirubinemia. Cystic fibrosis may also cause these two in conjunction, but would likely present with weight loss or failure to thrive and or other ciliary disorder symptoms. So patients with cystic fibrosis are usually much more unwell than this. This child, however, is fairly well, so biliary atresia is the correct answer. The incidence is approximately 1 in 10,000 and may be associated with other congenital malformations such as intestinal atresia or imperforate anus. It's surgically treated with the Kasai procedure. However, many will also go on to require a liver transplant later in life. So Guillain-Barré syndrome would cause an unconjugated hyperbilirubinemia. It is an autosomal recessive disorder which results in impaired bilirubin metabolism. Breast milk jaundice would cause an unconjugated hyperbilirubinemia, and it's usually mild. Both type 1 and type 2 Crigler-Najjar syndromes would cause an unconjugated hyperbilirubinemia. It is an autosomal recessive disorder that leads to impairment in bilirubin metabolism, which in turn can lead to brain damage. So it's important to have a basic understanding of possible congenital biliary abnormalities because these might influence your surgical planning and surgical management. So the biliary tract begins to develop in the 4th week of pregnancy. A hepatic diverticulum appears in the ventral wall of the primitive midgut or the duodenum, And then this develops into the liver, the extrahepatic biliary ducts, gallbladder, and ventral pancreas. So biliary atresia, like we discussed, is a congenital obliteration of the ducts, and it occurs in approximately 1 in 10,000, and it's often associated with other congenital abnormalities. A colloidal cyst is essentially cystic dilatation of the main bile ducts. It's much more uncommon and occurs in approximately 1 in 200,000. However, it is more common in patients of Japanese or Asian descent. So a duplication of the gallbladder, where the patient has 2 gallbladders, occurs in approximately 1 in 5,000 patients. Some patient may have a complete absence of the cystic duct, therefore the gallbladder opens directly onto the side of the common bile duct. And approximately 1 in 10,000 have no gallbladder at all. So thank you very much for coming today. If anybody's interested in more learning on paediatric jaundice and neonatal jaundice, there's another Quesmed talk on that, which you'll be able to access from YouTube.